Ah, Good evening, everyone. Good evening to our viewers. Welcome, and welcome to everyone to this CSSJ webinar in the series This is America. This is a series in which we create a platform for dialogue, for debate and conversation on some of the burning issues of our time. And in this case, the continued and sustained legacy of racial slavery and anti-Black racism, and how these structures of racism and anti-Black racism dominate aspects of our lives today. That's the nature of the series, the character of it. Debate, dialogue, and conversation around legacies and their importance in today's society. Today, this particular webinar examines race, justice, health disparities as barriers to equality and citizenship. To discuss and debate this topic, we have a really wonderful group of panelists. But before I come to them, one more housekeeping matter. This program, today's program, is jointly sponsored between the Center for the Study of Slavery and Justice and the IPC Philly chapter. We are honored to be in this collaborative effort, and I want to call on Steve Robertson to say a few remarks. Steve?
Yes, thank you, Dr. Bowes. Good evening and welcome. My name is Stephen Robertson of the Philadelphia chapter of the Inman Page Black Alumni Council. Thank you for joining us for the Race, Justice, and Health Disparities, Barriers to Equality and Citizenship panel. The Philly IPC, along with the Brown University Center for the Study of Slavery and Justice, are proud to present an esteemed panel of experts in the fields of justice and health. Born a slave, the first Black graduate of Brown in 1877, the class orator and valedictorian and president of 4 universities, Inman E. Page overcame and achieved against all odds. Inspired by his life, the Inman Page Council and city chapters throughout the country strive to carry his torch of excellence, lighting the way for future generations. In the spirit of Inman Page, tonight we hope to shed light on societal ills in order to redress injustice and advance the cause of human equality. The disproportionate number of Black lives lost to the pandemic, the killing of George Floyd and countless other Black lives, and the global Black Lives Matter movements have placed a spotlight on social justice and health disparities for all to see, and has revealed a level of marginalization that has existed for over 400 years and continues to exist today. Now that we are more aware, the question is, where do we go from here? Over the next 90 minutes, we'll hear from 4 experts who have a keen understanding of the justice and health disparities lived daily by Blacks in cities all across the nation. We hope to spark conversation, enlighten perspectives, and perhaps reveal possible ways forward to a more just and equitable society. We would like to thank Dr. Alicia Coates, Valerie Cordero, the Brown Alumni Association, the Brown Club of Philadelphia, our distinguished panelists, our moderator, Dr. Anthony Bowes, and many other Brown University staff for their diligent assistance and attention to detail. Again, thank you for attending.
I think it is now safe to say that, and we can say this without exaggeration, that our country is in a crisis. We are in the middle of a pandemic, which has gone on longer than was predicted or anticipated. a pandemic in which has killed disproportionately people of color. Importantly, as well, a pandemic in which its effects has been exacerbated by no national public health plan. And a pandemic in which medical science and quackery often clashed. In the middle of this pandemic emerged one of the largest protest demonstrations in the United States historically. Demonstrations of 26 million people, all marching around Black Lives Matter. Black Lives Matter began as a hashtag and as a set of exchanges between three remarkable Black women. Today, it is a national movement and a political banner, and a national movement and a political banner which has shook the United States and the world. This movement, born against the regular killings of Black folks, has catalyzed this country in unexpected ways, placing on the table, in a way perhaps as never before, the structural effects of anti-Black racism. The reaction of the American state was not to listen to these protests or demands, but in the words of President Trump, to dominate. And in that process of domination, and which is now in full public display, what we see are armed militias and white vigilantes, an American state attempting to define the protests as violent lawbreakers, while all the statistics point to the fact that all the protests were 93% peaceful. But the argument of Trump and the regime and others is really about a law and order with an eye to the November election. And it's really about how to recapture a ground lost between May and August. The elections, therefore, now stands before us like a gathering storm cloud, hanging before us in ways which many of us may not have thought possible. But we are living in a moment in which one needs to have a very clear and calm way of thinking about the next 2 months and what might happen after November. In such a context of gathering storm clouds, within a pandemic, within the historic largest protest marches in United States history, how do we calmly debate and discuss, separate fact from fiction, separate paranoia from thoughtful ways of analysis and propaganda? That is what we hope to do this evening. And to help us do that, we have really very wonderful guests. And I will read their name with a brief bios in the running order. That is the order that we invite them to speak. First, we have Larry Krasner, who's a district attorney of Philadelphia, who will be followed by Dr. Mallya, who's a senior policy officer at the Robert Wood Johnson Foundation and a past director of policy and planning at the Philadelphia Department of Public Health, followed by Dr. Carla Moreira, who's assistant professor of surgery at Brown University and is the section chief of vascular and endovascular surgery at the Providence VA Medical Center, and who was voted as one of the top doctor in Rhode Island by the Rhode Island Monthly, by her peers in the Rhode Island Monthly in 2019 and 2020. And then we have my really very good friend, Dr. Wilfred Codrington, who is assistant professor of law at Brooklyn Law School and the author of a forthcoming book, The People's Constitution. That's the running order for our speakers. They'll speak for about 10 minutes, followed by a Q&A in which I will ask some questions that have emerged from the discussion, and then followed by a Q&A with the audience itself. You are to use the Q&A function and raise your question, which will then be read out at the appropriate section of the webinar. So without further ado, let me welcome you all again and welcome this wonderful panelists, all the wonderful panelists, and ask Larry to lead us off. Larry?
Thank you so much, Professor. I have to tell you, I'm slightly bewildered at my invitation here. There are so many people who actually know something about medicine or have studied issues around race their whole lives. I've been running around a courtroom doing criminal justice or trying for quite some time, but I will certainly try to share with you whatever little things I may have that are of some use. Perhaps the most interesting thing that I've been able to do recently was a little bit of reading and a little bit of thinking and talking to some people. And I think much of what we are here to discuss tonight comes down to what is it that a government is supposed to do for its people. And let's start with the basics. They're supposed to protect you. In the most fundamental sense, government is supposed to protect your body. It is supposed to protect your autonomous body. To put it mildly, this is nothing new. This is something, for example, that Ta-Nehisi Coates has written about at length. And most recently, I had the chance to read Between the World and Me, in which I think he maybe distilled points that he'd been working on for quite some time. And it occurred to me as I read it that in my own experience within the courts, I have seen a multi-century topic with him. But it reminds me of 1987 when I came out of law school in the Bay Area, which of course at that time was considered the epicenter of what was referred to at that time as the gay plague. HIV, AIDS were ravaging gay men in that area, didn't even have a name at first, and soon went on to ravage Haitians, hemophiliacs with a blood supply that was not secure from spread of the virus. Virus, heard of a virus? I guess we're living through something else that's frightening, that has a virus in it. And what followed, when I first became a public defender in Philadelphia in 1987, which is where I began my career, what followed was what I saw when I was in jail, when I was fulfilling, frankly, the least important roles of my office. For example, doing bench warrant hearings in a jail. What I began to see was that the fear and the terror, the uncertainty was expressed by government in certain ways. So I'm sitting next to someone who is apparently a sex worker, a male sex worker. I'm in a male prison. And after that person gets done signing a subpoena, the jail guard approaches, takes the folding chair, goes to a back door, throws it out the back door, throws away the pen, because the guard is apparently so fearful he's going to contract HIV and AIDS from touching a chair. That was watching government in action. What I saw after that was 2 consecutive presidents who did not want to put any money into research for HIV and AIDS. We heard all kinds of things about it was God's will, things of that sort. And in that particular situation, ACT UP, the AIDS Coalition to Unleash Power, and other activist organizations rose up, and they got us where we are today, which is not a full-fledged cure, but it is medication capable of stopping the spread of a virus, and people who have been suffering with the virus their entire lives and will live out long lives on that virus. Well, that to me was government not protecting the bodies of its people. The virus, like all viri, spread, and it didn't just spread according to your sexual orientation. It spread to different populations. It spread throughout all of society, and it spread a lot farther and a lot faster because government did not protect the bodies of its people. Well, that is a failed government. It is a failed government that also does not protect its people. When jails are jammed, we become the most incarcerated country in the world, and a pandemic spreads. And we start to see that in congregate settings, such as meatpacking plants or cruise ships or county prisons. We have hotspots where the virus spreads more quickly than anywhere else. Take, for example, Cook County, otherwise known as Chicago, Illinois. At one point, several of the most rapidly spreading hotspots in the United States were custody. We faced this issue in Philadelphia, and it was a new issue for us because if you are a prosecutor, which has been my job since I was elected about 3 years ago, after 30 years of being in criminal justice and being a civil rights attorney in other ways, by the way, also, and I'm proud to say this, having represented Black Lives Matter, its members actually in protest during my 25 years of representing protesters. So we faced a new challenge. We have a challenge in public safety, and there is a terrible spike in shootings and homicides affecting, not surprisingly, but affecting and victimizing more people of color than white people. We have this terrible spread of this high level of gun violence in basically every major city in the United States during the pandemic for a lot of reasons we could talk about, but they're not the main topic today. But we also have to make sure that we reduce the jail population so as not to spread a virus within and then, of course, without. Because every single day you have guards coming and going, social workers coming and going, and they're going home to a place where there's a 90-year-old living and there are neighbors up and down the block, right? So we face this new equation, which is how much custody is good for public safety. We're now, and also for, preservation of our rights. We're also facing the question of how much custody is good for public health on top of that, and it became a balance. What happened in Philadelphia is more or less like what happened in some other places. A city that had 10,000 people in county custody several years ago, had 6,500 people in custody when I came into office, and due in part to some of our policies, had knocked down its county custody to about 5,000 before the pandemic, is now at about 4,000, which in a city where the population grows over time is the lowest level of incarceration that we have seen since 1985. And yet we still face spread of the virus. We still face what I consider to be another public health crisis, which is the spread of gun violence, homicides and shootings in Philadelphia and many other cities are up as much as 40% or more. The number of homicides in Philadelphia is up about 31%. The national average for large cities is up about 22%. There are cities where we're seeing an 89% increase in homicides and violence of that type. Again, for reasons that are not the topic tonight, but that we could certainly discuss. I think what we are seeing, not just with the pandemic, but in criminal justice and in the way we stuff our jails, is a common theme, and that is the failure of government in that we are not protecting the bodies of the people, and it is the obligation of government to protect people. There is a caveat here, though. They're pretty good at protecting the bodies of some people. They're just not very good at protecting the bodies of marginalized people. If you were a gay man or you were a Haitian, in 1987, they did not care too much about you. And if you are poor, and if you are incarcerated, and if you are of color, they don't really care too much about you now either. So we are seeing a very different level of protection of the people. We are seeing consequences in terms of physical health for African Americans and for other groups that are marginalized, that are clearly, unquestionably much worse. And whether it is symptomatic of other structural racism, whether it is symptomatic of other failings, the fact is, it is above all symptomatic of government failing, because it is not protecting all of its people, and it is not protecting marginalized people. That is my 8-minute and 34-second rant. I really am looking forward to hearing probably much more specific and interesting things from others, and I thank you very much for inviting me. I'm honored that you would.
Thank you very much, Larry. Dr. Mott.
I want to thank the Inman Page Black Alumni Council and CSSJ for this invitation tonight. We've already heard about why this is a crucial moment in our history, and we are going through a number of storms, but there are some rays of hope. We're seeing that now more than 20 cities and 3 states have declared racism a public health crisis. This has been spurred by police killings of Black people, and a global pandemic that has wreaked havoc on the bodies and livelihoods of Black and brown people. It surfaced really what many have known intuitively and experientially for centuries, that racism is a root cause of differences in health. But before we continue to look at the future, I think it's important to look at the past as prelude. Medicine and public health have a long, long history of grossly misdiagnosing the source of race-based health disparities. And I want to walk you through 3 myths that have been promulgated by these fields. The first is that is really based in the tenets of scientific racism. The idea that Black people are genetically and biologically inferior to whites, not deserving of agency, decency, or humanity. That's one of the things that spurred the slave trade and maintained it. But it also led to terrible injustices in the name of medicine. For example, in the 19th century, medical schools purchased the bodies of enslaved peoples stolen from cemeteries for anatomic dissection. We can also consider the case of Dr. James Marion Sims. He was known as the father of modern gynecology. He operated on enslaved women, not providing anesthesia, sometimes up to 30 times on the same women, to perfect what became a widely used surgical technique. And it was based on this technique that he became president of the American Medical Association. Yet, in medical school, we learn nothing about how this knowledge depended on Black bodies and Black minds. It turns out that many of Dr. Sims's surgical assistants were also enslaved women that were trained to help in the surgical setting. Looking back at the history of medicine science, I think is critical, and I want to just honor my colleague, Dr. Dwayne Proctor, who gave me the inspiration and motivation to do this. This is an area where I'm still learning because it's an area that was completely missed in my training. This myth of biological differences continues to harm today. So this is data from a 2016 study showing that 40% of white medical students and 25% of resident physicians endorsed the false belief that Black people's skin was thicker than the skin of white people. Medical students and residents who endorsed this belief rated Black patients' pain as lower than white patients' pain, and they made less accurate treatment recommendations. If we sort of pull back, this study reveals a potential mechanism for why Black people are consistently undertreated for pain. This has been shown among adults with cancer, young people with bone fractures, and even kids presenting to the emergency room with signs of appendicitis. Myth 2, so in addition to biological differences, medicine and public health have advanced the notion that Black people are behaviorally different than whites, that they have poor impulse control or deficient decision-making. This idea has been used to explain racial differences in obesity, teen pregnancy, drug use, along with a whole host of other issues. We really need to look no further than how we as a society have differentially responded to the crack and opioid epidemics. One, seen as predominantly affecting Black populations, was treated as a moral failure and as a criminal justice matter. The other, which was seen as predominantly affecting white populations, was considered an illness, deserving of treatment, rehabilitation, and even mercy. The third myth is around the social determinants of health model. On the one hand, this model rightfully points to the fact that people's social and economic conditions have a huge impact on their health, and that's right. But the problem is the analysis often stops there, and we don't ask, why is it that we see racialized differences in access to these social determinants? There's a small nod to the idea of discrimination in the model, but it's really a fully inadequate view of how interpersonal, institutional, and structural racism dictate opportunity and outcomes in health. I want to talk just briefly about Philadelphia. What you see here on the left is a redlining map from the 1930s, and on the right, a map showing low birth weight births in the city. And what this shows is that areas that 100 years ago almost were deemed hazardous or declining, and then subsequently suffered from public and private disinvestment. It's these same communities today, many of the same communities, that see high rates of low birth weight birth. And it gets at this idea that racist policy of the past continues to affect our present day health. I want to turn a little bit to what we're doing as a national foundation dedicated to giving everybody a fair and just opportunity for health. We know from data that Black and American Indian women and babies have the highest rates of mortality. And in the case of pregnancy-related mortality, we also know that college-educated Black women have a 60% higher rate of death than white women with less than a high school diploma. This has to demonstrate to us that it's not about income, it's not about education, it's not even about access to care. And I think the insights into why we're seeing these differences, some of the most important ones are coming from Black women across the country. Physicians, midwives, doulas, leaders of the birth justice movement, and Black mothers. What they're revealing is that drivers of these disparities in maternal mortality include discrimination in treatment, people not being offered all the options that others are, people's concerns not being taken seriously, even in emergent moments where critical medical care needs to be provided immediately. Second is a lifetime of discrimination and how that has real impacts on people's biology. And then the third is we see over and over again that Black people receive poor quality care, whether it's related to maternal health or a broad range of other issues. This work at our foundation is being led by one of my colleagues, Dr. Monique Shaw, and I definitely want to credit her for her leadership. One of the things that we're doing is that right now there is no metric for a patient-reported experience of mistreatment and discrimination in the birth setting. So we are supporting the National Birth Equity Collaborative led by Dr. Joya Creer-Perry to develop this metric. She's working with Black mothers, leaders from the birth justice movement, to create this model, to test it, and then eventually disseminate it to medical care across the country. Ultimately, what we hope with this metric is that it's a way to hold healthcare professionals and health systems accountable and a way to improve their quality of care to meet the needs of Black women before, during, and after pregnancy. We are also supporting national advocacy to change policy. Everything from diversifying the perinatal workforce, improving care for pregnant women who are incarcerated, and even extending postpartum Medicaid beyond 60 days. I'm going to shift a little bit and talk about a seemingly unrelated policy issue, and that's minimum wages. There's a growing body of research showing that there are real health benefits of increasing the minimum wage. For example, in a recent study, for every $1 increase in the minimum wage beyond the federal minimum, we can see a 4% decline in the rate of deaths among infants between 1 month and 1 year of age. That is clinically and population level significant. There are several pathways by which wages can impact birth outcomes, and this needs to be explored more fully. But as we are seeing these health impacts, unfortunately, localities are facing increasing barriers to enacting minimum wage increases. Right now, 25 states prohibit cities, states, and counties from raising their minimum wage beyond the state or federal minimum. This is called state preemption. It's a legal doctrine. And in the minimum wage space, it's really been driven by corporate interests that are trying to hold down wages and not give people economic opportunity. It's also rooted, as you'll see, nearly all the states in the South have minimum wage preemption. It's really rooted in a long history of power being centralized in state legislatures to disenfranchise, particularly Black folks, economically and socially. So again, there's a history here that helps us understand our present. Maybe one of the best examples is in 2016, Birmingham, which is 62% Black and has a city council that is entirely Black, passed a minimum wage increase to increase wages from $7.25 to $10.10. The next day, the governor passed a law reversing that decision. Fast food workers and the NAACP sued the state, claiming that this was a violation of equal protection. They said that the state law was passed in a rushed and non-transparent way, that it had a disparate impact on Black workers, and that it reflected this long history I talked about of the state legislature thwarting actions to improve the well-being of Black people in the state. Ultimately, they lost this case, but it brought great public attention to this issue of how racial equity, economic equity, and health equity really intersect. And you can see here what a panel of judges said. And really what they highlighted is that race-neutral laws don't have race-neutral impacts, and we need a way to address those types of policies through the political process. We are supporting a number of advocacy groups at the national, state, and local level to block the passage of new laws like this, to repeal ones that exist, and to reform the relationship between state and local government. Just over the past couple of years, we have blocked preemption laws in about 30 states across a broad range of issues. And Colorado last year became the first state to repeal minimum wage preemption. So now cities in that state can increase their minimum wage beyond what the state minimum wage is. I just want to close with this quote from Rudolf Virchow. He was a German physician. He's known as the father of pathology, and he was actually an anti-racist advocate. He debunked many of the German Reich's attempts to establish scientific racism and to show the superiority of the Aryan race. So he said medicine is a social science and politics is nothing else but medicine on a large scale. And for me, what that underscores is this idea that our decisions, whether we make them in a clinic or in the Capitol, have consequences. And we can either bend toward or away from justice. And I think what we're hoping to do with partners is to make sure we are bending towards justice. Thank you.
Thank you very much, Dr. Mallya. Thank you. Really, thank you very much. Our next speaker is Dr. Clara Moreira. Let's move on. Wilfred Codrington. Dr. Clara is also an emergency physician, so she may have been called out. Yeah.
First, I want to thank Brown and the Center for Study on Slavery and Justice for hosting this wonderful ongoing series, This is America. I also want to thank the IPC, specifically the Philadelphia chapter, of course, to my distinguished co-panelists for all of the work you're doing to advance the cause of justice, and especially to you, Professor Bogues, for your vision and the accomplishments with the center. Even as I am honored and humbled to be a part of this panel, I must admit to you, like Larry Krasner, I'm a bit surprised to receive the request. That's because the stated focus to explore the legacies of racial slavery and the presence of racism in the US, and to examine the impact on criminal justice and health disparities in African-American communities. So I was surprised because I am not a criminal justice scholar. And while I'm interested in it, my expertise goes as far as being a Black scholar repeatedly and wrongly been treated as a suspicious criminal suspect. I can't claim to be a health scholar, unless by a health scholar, you mean an A student in high school AP biology and the occasional reader of WebMD to self-diagnose my own athletic injuries. Instead, my work focuses on constitutional law and election law and policy, often thinking about their interplay with race. So I struggled a bit how I might discuss the aforementioned topics that I might not be any better equipped to discuss than your average curious academic. But it's the year 2020, right? We have seen the convergence of these things. We bear witness to our failed criminal justice policy and a disastrous public health platform, and that's coinciding with our flailing democracy. This year has been the epic reminder that American democracy is being held captive, like the millions of citizens behind bars. It's a reminder that American democracy is grappling with a sickness like COVID's millions of patients. We are facing, as Dr. Bogues said, overlapping crises in America, and unsurprisingly, the impact has the direst consequences for Black and Brown communities. How did this start? Well, I was on a panel earlier today commemorating Constitution Day. Today, some 233 years ago, a few dozen men signed the US Constitution right here in Philadelphia, and then they set off to see its ratification. So it's rather fitting that the IPC Philadelphia chapter is hosting this event. Philadelphia so often being credited with the birthplace of American democracy. But by that very same token, it is where that captivity and the sickness of that democracy was born, because it is here where slavery was officially sanctioned as the policy of the United States. Of course, slavery was not born here. American slavery was definitely not born here. And in fact, Philadelphia was home to some of the most radical anti-slavery and abolitionist voices of its time. And yet, it is here where the men who touted fundamental value of liberty so cunningly and so because as they made deals about the structures and limits of American government, they horse-traded about Black bodies. They included the slave trade clause to give states an additional 2 decades to amass Black bodies, violating their liberty as free labor and worse. They included federal government to be co-opted, even alongside civilian bystanders. As I said, they included the Fugitive Slave Clause. The Fugitive Slave Clause allowing the federal government to be co-opted and civilian bystanders to hunt down those seeking nothing more than their own taste of liberty. And then because of the 3/5 clause, which worked hand in glove with the structure of the US House of Representatives and the Electoral College, run-of-the-mill, wealthy Virginian slaver, like James Madison, the father of the Constitution himself, possessed the political power of men in Massachusetts. Your vote, the weight of your vote was going to be unequal in the vote for the president. That it's going to depend on where you live. And if you live in the South, the majority of Black Americans, your vote has been canceled. A man of the vilest sort to win the presidency, despite his inability to command the popular vote, justice, and health, and democracy.
My apologies again to all the.
One second.
I think we really having some technical difficulties. Can we begin by just asking, going back to Larry, while we sort this out. The business of homicide in Philadelphia, as to why do you think there has been this spike in homicides in Philly?
Well, I will speculate with you like the best of them, but I've had a lot of conversations within the system with people, and I can tell you the things I've heard that make some sense to me. So here are a couple of factors. You have policing that is quite different and more limited in a variety of ways. There was a decision, for example, in Philly made for several weeks that only certain types of offenses would result in arrest. And that was done in large part so that police officers would not spread the virus, for example, by arresting people for what were considered to be not the most serious offenses. In some days, we went from 115 arrests to 15 in a city where ordinarily you have 35 to 40,000 cases. And at one point, we had 70,000 new cases per year. Probation and parole supervision essentially ceased to function. No visits, no drug testing. Many supportive programs for people who were out of custody disappeared. Virtually terrible unemployment problems and virtually all supportive programming for youth in the summertime disappeared. Budget cuts or fear about spreading the virus, closed schools, closed camps. All of that was going on. The court system, for the first time in my career, shut down almost completely, we went through several months, almost 6 months, of being completely unable to resolve cases. And so the two aspects of deterrence of crime that do seem to be real, which are the certainty of being caught and the swiftness of punishment, were much reduced. The length of the sentence seems to have no impact, but those two were much reduced. There is also, I think, an interesting analysis, which is very simplistic. You know, in Philly, we have an issue with groups. We don't call them gangs for a variety of good reasons, but there are groups of people who shoot at each other. And they do so repeatedly and in a retaliatory way. They actually brag on social media about which side has more numbers, by which they mean more bodies or more shootings. And previously, this went on, but it went on with a lot of witnesses on the street. And it went on in a way so that people were required to be at least warier. If they were going to lurk in a car and wait for someone to come home for 2 hours, they would be quite noticeable. But when the streets are empty, that becomes a different thing. Another point that has been raised is simply that people who are engaged in that kind of activity, and in my view, usually because they come from a place of hopelessness about their future, they believe, and I've heard this thousands of times, at 16 that they will not live to be 30. They expect to die soon. In many ways, there is a glamorized violence and an admiration for people, including people who've been killed, doing this type of activity. You know, when you're talking about that crew, they are not worried about wearing masks and staying home. So you might say this is a self-selecting group of extreme risk takers. And while the rest of us are home, they are not shy about being out and about and going to the places where they still can go, which of course is very much reduced, restaurants closed, et cetera. So, you know, these I think are some of the factors. I am describing, though, for you just a wink, just a moment in time. You know, the reality is that Philly is chronically more violent than other cities, and it is chronically the poorest of the 10 largest cities. It has, despite a lot of good teachers, a failed public school system where about half the people never graduate. We have a city considered to be very hostile to business, and new economic opportunity simply is not there. And we have long and terrible histories of structural racism. And so I am talking about a moment in time, but it is only a moment in a very, very long and lamentable history of disinvestment in community-based organizations, economic opportunity, and things that work, and reinvestment in having one of the largest, proportionally largest police forces in the United States, and in extremely high levels of custody and supervision. None of that has worked, which is part of the reason I ran for DA, is that we have to get back to a different model.
What is the kind of model you think that you think can manage this kind of situation? And isn't that, it's not just, it doesn't seem to be just a juridical model or a legal model, but seems to be very much rooted also in trying to reverse social conditions. Would that be an accurate assessment?
I think it is, and I think this is where medicine can claim a certain amount of victory. Medicine has, at least in part, moved towards a prevention model. We don't address cigarettes by promising to have an infinite supply of lung transplants. We address cigarettes by trying to persuade people not to smoke, and by doing other things to try to persuade them not to smoke. It is a public health model that I experienced from high school on, when smoking cigarettes was deglamorized, and it has worked in many ways with other forms of regulation. But that is not what we do in criminal justice. What we do is we have been following the fraud that if you give the death penalty to someone who has killed someone else, that is somehow justice, when it is all at the back end. You know, we can either prevent crime in the same way that we prevent disease when we're doing a good job, or we can just leave it some comic book where it's all about revenge and retribution, and a comic book that is based on the notion that people are unchangingly bad or good. People are not. They are actually capable of tremendous transformation. And that, to me, is the crack foundation of the thinking behind the criminal justice system. It is that people are unchangingly bad or good. And needless to say, I think we all know, based upon the, as you put it so eloquently, the anti-Black racism of our society, that certain people are always characterized as bad.
Okay, great. Thanks very much Larry. Wilfred is back. Can you hear us, Wilfred? Can you come back on?
I can hear you. Can you hear me?
Yes, I can hear you. Good.
All right. I'm back. I'm sorry for that. Now I'm back on my phone. So hopefully the internet stability would be a little better.
Okay. Can you pick up where you left off, please? Yeah.
Yeah, sure. So I was saying what we're seeing is the confluence of all these things. And we're seeing the president use his post to aggrandize the problems of criminal justice and healthcare and democracy. We're seeing it in 2020 that we have the loser of the popular vote using thinly veiled racist language to cast Black and brown people as inherent dangers to the suburbs and American society more broadly. We are seeing the loser of the national popular vote use the nation's highest platform to publicly deny the virulence of a virus that has so disproportionately sickened and killed Black and brown people, despite having admitted the true tragic facts to journalists. We know that the popular vote loser is using his office of trust to strategically sow discord in advance of an election again, threatening to send in federal law enforcement to intimidate voters, employing the Department of Justice to lie about the nature of their prosecutions, to make it seem as if there's a problem with voter fraud. And after he has declared a war on the post office, the Postal Service itself, a constitutional office, his campaign has filed a suit here in Philadelphia and Pennsylvania to forbid the use of special ballot boxes to prevent folks from voting in a safe and secure way in this pandemic. This is sick. Then what happens? I said the 13th Amendment was passed, adding abolition and ridding the Constitution of its slave provisions. But these men also knew that by abolishing slavery, all those Black people in the South, all those former slaves who could not vote, they would augment the South's political power even more. And that's because now they were not constitutionally 3/5 of a person, but 5/5 of a person. How do they address this? Well, instead of a complete overhaul of the electoral apparatus, they put in a provision of the 14th Amendment that included a mere threat to reduce the representation of states that did not allow Black men to vote. I say that was a mere threat because that provision has never been used. It has never been used despite the bleak picture that Jim Crow and his redeemers painted throughout the old Confederacy and beyond. It has never been used despite the passage of laws to disenfranchise Black people with surgical precision and the systematic violence and intimidation that accompanied it. The other little jewel in the 14th Amendment, Section 2, which permits states to bar voting to those who have participated in rebellion or other crime. The implications of this is obvious. Criminalize Black conduct, and you can legally disenfranchise Black people. There's your solution. And we saw this occur post-haste. In Alabama, vague terms like crimes of moral turpitude combined with the discretion afforded to racist actors, well, that could mean just about any crime would keep you from voting if you were Black. And unsurprisingly, they impacted Black folks disproportionately. They impacted Black folks 10 to 1. But these criminal disenfranchisement policies, these unbroken links to Jim Crow itself, they continue to affect us today. In 2018, just 2 years ago, 64% of Florida's voters approved Amendment 4. It was an overwhelming show of support to amend the state's constitution for the repeal of its felon disenfranchisement provision. And like clockwork, the state's Republican-controlled legislature passed a law to limit the impact of a repeal. A pay-to-vote law they passed, without telling you how much you had to pay. All to ensure that in 2020, so many of those 1.4 million Floridians who served their time and would have otherwise been eligible to vote can't. And just last week, a federal appeals court judge or panel flip-flopped on their earlier decision and overturned a lower court judge to permit this trickery to stand. The dissent in that case compared the law to requiring Floridians to count the number of jelly beans in a jar. Our democracy is being held captive. Finally, in 1965, Congress succumbed to pressure and adopted the Voting Rights Act. It passed a statute, and it was a powerful one. But this was in lieu of a full affirmative constitutional right to vote, as some has recommended and some still recommend. While the Voting Rights Act accomplished a great deal, it really only did the things that the 14th and the 15th Amendment should have accomplished a century earlier. Nevertheless, after its passage, Black registration soared. In Louisiana, in 1947, registration was at 2.5% for Black people. But in 1966, 1 year after the Voting Rights Act passed, it was at more than 47%. Mississippi, which was less than 1% in 1947, it was at 33% in 1966. But the Voting Rights Act, it was targeted early and often. It was challenged in the very year it passed, and so many times after each of the 5 times that Congress reauthorized it. The last time that Congress reauthorized it in 2006, the Senate voted in favor of it 98-0. But finally in 2013, those challenges caught up with the Voting Rights Act. The Supreme Court invalidated its most potent section. Despite 15,000 pages of congressional records suggesting to the contrary, the Supreme Court said that the coverage formula was no good. No good. It violated state sovereignty. Congress can pass a new formula, the court said. This Congress that can't even pass legislation for the assistance of Americans facing a pandemic. The impact of that decision is that states can pass onerous voting laws, even requirements that make it more difficult to obtain the ballot during the middle of a pandemic. This democracy is sick. I guess I'll close by saying, while we are re-examining our criminal justice policy and searching for solutions to mass incarceration, we also need to be looking for the key to unloose this democracy because it is in chains. While we are testing for a vaccine, we need to be looking towards a cure to the ills that are currently plaguing our democracy, because much of this is the manifestation of that little virus called slavery that was planted in our founding charter some 233 years ago today. And we know that racism that has fostered slavery and the slavery that has in turn fostered racism is virulent. It mutates. And Black and brown people are particularly susceptible to it. So we all need to do our part here. And my small suggestion, it starts with a little act. Please vote. Thank you.
Great. Thank you very much, Wilfred. Thank you very, very much. Okay, let's turn to the Q&As. Catherine, have you got some questions there for us?
Yes, we do. So the first question comes from Monica, and Monica asks, how can solo practitioners help reduce health disparities?
Can we ask Dr. Malawi on this, please?
Well, I think it's a twofold answer. One is what a provider can do in their clinic setting, right? And I think there are a couple things. First is look at outcomes for your patients by race and ethnicity, and understand over time whether outcomes look different, and then begin to investigate why those outcomes look different. And think about the things that are within your control and the things that are outside of your immediate control. So for example, things that might be within your control are ways in which you engage patients in shared decision-making. That tends to happen much less often with Black and brown patients than it does with white patients. Second, there are recommendations that we often make that are quote unquote standard of care, but they tend to not take into consideration what people's social and economic conditions are. And that needs to change. Advising people to eat healthfully or exercise when they are struggling to put food on the table or can't go outside with their children because of fears of violence ends up being a useless recommendation. The other part of the recommendation, the other part of what solo providers can do is think about themselves as citizens. Doctors have historically, and particularly doctors' guilds like the American Medical Association, have powerfully fought against a national health plan. That needs to change. And I think we're seeing among a new generation of doctors and even past generations, they're seeing that they need to be engaged politically and they need to create a voice among health professionals to ensure that everybody has access to care. So that's everything from voting to engaging civically in your local community, to understanding the powerful role that doctors' voices can play in educating political leaders about why we need expansions in healthcare coverage.
Great. Thanks, Brian. Another question, Catherine.
The next question comes from Robert, who asks, does the current COVID vaccine testing have a representative percentage of African Americans?
I think that's you. I think since you're the only medical doctor.
Okay.
That's you again.
I'll take it again. I think what we're seeing right now is emblematic of what we tend to see in a lot of early stage clinical trials, and that is there is not tremendous participation from people of color. And that has historical roots. I talked about the ways in which the medical system has exploited and done violence to Black people and Black bodies, and that carries forward today. There is a mistrust in the medical system as a whole and also in the clinical trial system. So my understanding is that so far, the 5 companies that are developing vaccines are still trying to work very, very hard to get more people of color to participate in trials. What I think that requires is complete and radical transparency as to what they know about the vaccine now, complete and radical transparency on what the outcomes are of patients, particularly related to patient harm. And then it's also essential that leaders of these vaccine trials reflect the diversity of America. So they have a long way to go before we know that that these potential vaccines are safe and effective for everybody in this country.
Okay, great, thank you. Another question from the audience, please.
I'll give Dr. Mallya a break here and ask, this question comes from Leisha, who asks, what are some legislative efforts that can be progressed to address some of these legal issues? What should the electorate focus on?
Sure. So I guess it depends on which of the legal issues we're talking about. A lot of the ones I focused on relate to democracy specifically. I raised the Voting Rights Act, which was gutted, obviously. Congress can start by restoring that, by actually trying to pass that. That's going to depend on the outcome of an election. The way that things are now, the House has passed it, so it very much depends on what happens with the Senate and what happens with the president to sign that into law. I think immediately, we are looking at a very closing window. So some of the things that need to happen to make sure that this particular election goes off without a hitch need to happen post haste, like immediately. It is really, the difficulty here is that our election system is divided between the federal government and then the state governments. So Congress can do a lot. Congress can do a lot by funding and helping states to overhaul their failing voting machines and registration systems and other things that foreign actors are hacking in. But then it also requires that the state legislators get invested in this too, that they start passing laws to make sure that criminal disenfranchisement is not the policy in their state, or to make sure that they're not passing onerous voter ID laws, or to make sure that that they can ensure that people can vote by mail or drop off these ballot boxes. A lot of these decisions are made up at the state level. So in terms of the immediate, as I said, the window is closing to get this done for November. Judges actually start looking at any changes very skeptically towards an election because they don't want to create confusion for voters or election officials. But I think if there is an actual receptive Congress elected after this point, there's a lot that they can do. And hopefully, I know the organization I work with is doing a lot to try to influence that. But again, so much depends on a good election.
Thank you, Wilfred. Any more questions from the audience?
Yes, we had 2 questions come in for DA Krasner, so I'll combine them here. Republicans have recently been attacking, quote, progressive DAs, and you've been called a progressive DA. What do you see as your mission, and why would that be attacked? And what programs are you putting into place that you believe will combat the institutional racism that's built into the criminal justice system?
That is a wonderfully huge question. Let me see how concisely I can answer. Yes, progressive DAs all over the country are under attack. They have been winning in big cities. They have been winning re-election in big cities. And actually right now, speaking of elections, George Gascon is running in LA to become, which is the largest criminal justice jurisdiction in the United States, and looks like he is very likely going to win as a progressive DA. So yeah, they're a little worried because when all the big cities have progressive DAs, then the drivers of mass incarceration have people going a different direction, right? Why does Trump hate us? Because, I mean, we've been here before, haven't we? He hollers law and order. This is the most lawless president, at least since Nixon, and I think since before that. There's complete disorder in this country during his administration. So they're looking for people to blame, and it's true. It's not even a dog whistle anymore. He is explicitly a white supremacist. He is open about it. He talks about it all the time. So it's playing into his talking points, his effort to rally his white supremacist base and then skim off a few other votes so that he can actually not win the popular vote, but still, you know, the way everything is gerrymandered, can still become president again. What do progressive prosecutors stand for? I think more than anything, they stand for the United States ceasing to be the most incarcerated country in the world. That's not what the land of freedom is supposed to be. They stand for shrinking the footprint of the criminal justice system in order to invest in all of the things that prevent crime and heal society and make it whole. I could tick off many of them, but I think there are too many brilliant things for other people to say for me to keep nattering on.
Another question, Catherine?
Yeah, this is open to all of the panelists in their particular fields. This question comes from Etzer, who asks, many speak of reparations as the way to at least try to correct the racial wrongs that we've seen historically. What are your thoughts on reparations as a means to address the history of racial injustice in this country, and in what form, financially or otherwise, do you think reparations may or may not be the most useful long-term strategy?
Wilfred, could I put you on the spot with that? Because I know you've been thinking about this.
Yeah, I'm happy to answer this first, and I invite anyone else to chime in what they think. I think reparations can do a lot. I think one thing is I try to stay away from using the word reparations, even if we're kind of talking about that same thing, because I think in this country, that word has become toxic with some communities. So as long as you say it, people are just going to, they have more questions than they even want to be open to the idea. So they'll say, well, what if people aren't really descended from slavery? Well, we know most Black people in this country, Black people are the largest group of people who have been here the longest. So they are descended. But they'll say, well, what about those people who don't really need it? Well, we can look at statistics and say that most Black people, you look at the socioeconomic factors and you can say, yeah, they do need it. Because when a Black family has $13,000 in income and a white family has $130,000 in income, you just see the disparity there. So, but I do try to stay away from the word reparations because I do think that it often ends the conversation before it starts. I do think that when we're talking about them, though, I think that they should be targeted. I think there are a lot of ideas out there in terms of giving direct dollars. Economists will talk about giving money directly to people to being the most efficient allocation of funds because they know what they need most, right? That's why people have advocated for cash or money on a card, but like food stamps in a way that are restrictive in terms of what you can spend. So there's that. There's you can target it towards education systems where we know we have census data. We know where Black people live. So we can look at the school systems that are supposed to be serving them and see how underfunded they are and bolster that. We can look at the housing stock that has been redlined in history and where they are living according to census data and use the money and target it and bolster it there. We can use it towards the health systems that are in their communities, especially community clinics that are there to serve them when other larger institutions are not doing the job. So you can bolster them there. So I think there's a lot of ways we can think about what to do with reparations. I think we just need to get over that initial hump and get people in the room and talking about it as if it's a real possibility and not laughing it off the stage outright or dismissing it because of all the questions that it raises.
Can I ask you a question, Wilfred? When we think of reparations, can we also think about a larger, not just about the giving out of money, which is how some people like to reduce it, but to try to think about a process of reparative justice? In other words, thinking about how do you correct a historical wrong? What are the things you need to do in a society structurally that can correct a historical wrong? Does it help to think about reparations alongside reparative justice?
I think that's right. I think there are, I mean, before you get to reparations, you have to get to other things first, right? Like you have to have people acknowledging the problems that have. And we have climate deniers, we have race deniers, we have birthers, we have people who deny this stuff. So first of all, we need to flesh out the facts of what has happened with slavery and racism and the legacy of both. And then what you need to do is actually, you have these facts and think about what that restorative process would look like. People need to atone. And we can start with large institutions. I know Brown has done that. And that's the reason why we have the Center for Slavery that you're heading, Dr. Bogues. Other institutions have admitted that they have a role in slavery. Lots of the oldest schools and other organizations. So when they do that, then they can do their part to atone for these things. And that can be part of the restorative process. But there has to be some sort of acknowledgement and atonement there. And then we can talk about what's going to happen in terms of like what the policies and the possibilities are in terms of making people whole. And that making people whole, you're never going to make people whole for all of the wrongs that have occurred over the history of 400 years or what have you, but at least you can make things half right. Right, we can be directed towards a better outcome, and so all the disparities that I talked about and the other panelists are talking about can actually be decreased in a way that allows Black people and other communities who have been wronged by the government and private actors with the government's consent, allow them to become whole and live their lives in a way that allows them to flourish.
Great, thank you very much, Wilfred. Again, I wanted to apologize to our audience for technical difficulties, but I'm now told that we have Dr. Carla Moreira back with us. So if we could give her some time, Carla, it would be great to have you on the screen to speak.
Yes, good evening, everyone. I apologize for the technical difficulties I've experienced and having missed some of the conversation. I won't, use 10 minutes other than to say that I think this is a great opportunity in terms of the discussion that we're having. And one of the ways in which persistent, racial disparities in health outcomes. There's a historical example going back in terms of this is the legacy of slavery. And this is also the legacy of ignoring those conversations that really link how we have racialized health, and we have used, racism, structural racism, to unfairly target certain communities, while also unfairly giving advantage to other communities. And that has projected, and we see that in terms of these persistent, health disparity. You can think about from the beginning of, in terms of Africans being brought to this country and, being treated very poorly, with receiving no medical attention, to the example of COVID. COVID, I think, is a continuum of the impact of racial discrimination, racial inequities in terms of health is a continuum, and the cumulative effect of the historical injustices that created and then perpetuated inequities and in terms of health inequities and disparities. So to me, hopefully, this COVID, as we come away from it, I think the idea that there's a raised consciousness in the country in general, not just of the communities that have been, disimpacted or impacted disproportionately from this pandemic, but that there seems to be a raised consciousness in our country, where the denials about the effects and the kind of the persistent legacy of racism, we are finally going to start having those national conversations. So, and this conversation, I think, is really important. Hopefully, I get an opportunity to participate in future conversations and not have any more technical issues.
No, I am absolutely sure we will invite you again, because your voice is critical. But I want to ask you as a question as a practicing clinician, as well as somebody who teaches at Brown University. How do you think about medical knowledge in this period? And as racialized medical knowledge shape the ways way in which people have, the medical profession has thought about COVID and what to do?
I mean, of course, I think that context of who's able to participate in terms of the safeguarding of knowledge, and sometimes I think in that sense, even within medicine, the certainty of certain of our own opinions, or certainties of medicine, as we're seeing with COVID. I think COVID is an example where we've had to change our approaches as we had new evidence, as facts came in. And I see that same way in terms of how we teach, as we have diversified the teachers and bringing people that can challenge assumptions that are harmful to the groups that are being taught, the subject matters, broaden the way that we discuss race within medicine. Especially, I think I've been very encouraged with a lot of the conversation that has happened nationally in terms of eliminating really race-based medicine, which we know that race is not a biologic principle. It's a social construct. So for example, when we calculate renal function, for our patients for a very long time, we have used correction for African Americans, and that implication of that and potential, the harm that has happened over these many generations. So it took the diversifying of the healthcare force, the diversifying of doctors and people to come in and really challenge some of these assumptions. So in that way, and when I talk with, when I teach and with residents or students, is to be open to learn and to incorporate new information in terms of how we approach, and to bring in different voices that's going to challenge your own assumption, and that's going to push the envelope and allow you to really center those conversations not on what has for a long time been a kind of the predominant voice in medicine. It's been very much, until recently, a very white male, upper middle class, voice. And that has certainly, hopefully as that continues to change and we bring in people from different backgrounds with different experiences, can help to us really ask better questions and be more thoughtful in terms of how we ask those questions, and really build knowledge that is going to be helpful, and that is cautious about racializing or ascribing biologic or characteristics to really traits that should not be, especially in how we treat patients, and really heightening our sense of our own biases and how those can affect how we interact with the patients and the kind of care that we provide them. So the conversation certainly has changed, but that conversation has changed only because we have brought in different voices and diverse voices, and that can push and challenge the normative and the status quo that, it has been harmful, frankly, has been harmful to minorities, especially Blacks and other minorities in this country.
Okay, great. So what you're saying is that there's still work to do.
Yes, there's always work to do. There's always, the work continues.
Okay, great. Catherine, can we get some more questions from the audience?
Yes, and thank you to all the audience members who have submitted questions. Unfortunately, we won't be able to get to all of them tonight. I think we only have time for a few more. But this question comes from a Philadelphia school district teacher who asks, I'm wondering whether any panelists can speak to the disparities in mental health care and how those may converge or contribute to the other issues facing Black communities that were brought up today.
Thank you. Any of the medical doctors would like to speak to that?
I'm happy to, but Carla, would you like to speak to it?
Yes, I mean, I think throughout, in terms of when we look at health disparities and access, so mental health from a very broadly in terms of the stigma and the access to be able to get care, as well as, we know there are studies that have shown that, especially women, Black women, in terms of their complaints and their pain being taken seriously and being considered in a thoughtful way that can actually help them. So there's this whole historical barriers to getting access to care from a socioeconomic perspective, from where you live, what other resources are available within your own community. But that is part of, this idea of this, I think, this kind of shared trauma, I think, for this theory about, African Americans or people who have been minorities that have experienced racism, and that there's this chronic trauma that internalize, and that can actually affect your health and affect your mental health. And when you compound that with all of the other, economic and issues that we talked about in terms of access, and then those things also can cumulatively continue to perpetuate the disparities in terms of minorities getting the help that they need.
Right. Do you want to add anything to that?
I'll just add really quickly. I completely agree with Carla. This is such a pressing issue now. Data from the CDC just from a couple of weeks ago showed that 1 in 4 young people had considered suicide in the last 30 days because of all the stresses that we are facing societally, and the numbers were higher among young people of color. So there is a critical workforce shortage of mental health professionals, particularly in the pediatric sphere. And it's even more acute among people with public coverage like Medicaid. There needs to be a really robust response to that, both in terms of creating a pipeline of more mental health professionals, particularly from communities of color, and then reforming payment systems so that people who have coverage through Medicaid can access healthcare, can access mental health care. And this is actually a common issue across public and private insurance, but it's particularly acute within Medicaid. Last thing I'll mention is to reflect this panel, we're seeing how issues of mental health, criminal justice are coming together in the streets, right? We need different systems to respond to mental health emergencies, and police should not be the ones who are leading the charge.
Great. I think that's a really very good point, given what happened in Rochester in this year. Catherine, any more? We have two more minutes.
Yep. This next question comes from Anne, who says, the conversations on health disparities always focus on the problems and potential causes. Can any of the panelists share experiences with equity in health, or examples where communities or specific groups have been able to exercise their power to achieve improved health outcomes for communities of color?
That's a big question. I'll just go back to this birth equity issue. I think we are seeing amazing solutions coming from the grassroots. So for example, there are models developed by Black women to create peer and social supports, to offer advocacy in the birthing setting, particularly through doulas and midwives, and to create an environment that protects, to create a set of social supports that protect against racism in the medical system. I can point you to the work of Jenny Joseph in Orlando, or even the work of Dr. Joy Perry that I mentioned before. One way that's playing out is through centering pregnancy models, where groups of women, and in some cases groups of Black women, offer peer support to one another as they navigate their way through the healthcare system. And it has been shown to be one of the most effective ways to reduce disparities in birth outcomes. So that's just a really small example of how we're seeing solutions.
Carla, can we give you the last word?
No, I was going to, in particularly as it pertains to maternal mortality in terms of death for Black women, and I think that had been really a wake-up call and a call to really organize and at the community level, where Black women have empowered themselves to provide the support that we're not getting from either the healthcare system or the organizations where are supposed to be there to help them. So that's one area that I think I am thinking about where this idea, and it's also the application of this the critical race theory in terms of how to bring together different different modalities that is not the standard or what we have applied in terms of these solutions, and really centering the problem on the patients and that have been historically underserved versus the institution that has done the underserving. So that's one example that I can think of that has been a lot of great work has been done.
Great. I think that's really a good note to end upon. It's 7:30. I would like to thank all the panelists for their contributions. My apologies again, audience, for some technical difficulties which we had to solve as we were rolling. And my thanks to media services, and real thanks and deep thanks to the CSSJ staff, particularly Catherine, who does a lot of this work for us. Again, thanks to the IPC for agreeing to host this with us. I hope this is the beginning of a series of programs that we can all collaboratively do together. This, I think, has been a very robust discussion where we were able to come from different points to think about questions of race, criminal justice system, health, and the current moment that we're in around voting and the importance of the upcoming election. So once again, thank you all very, very much for participating, and take care of yourselves. And have a good night to everybody, and stay safe. Good night.
Thank you. Good night, everyone.
Thank you.
Good night, Professor.
Night.
Thank you.